very big welcome to our webinar on phagenics. And I'm Sarah Wallace, and I'm a consultant speech and language therapist at Wythenshawe Hospital in Manchester. I specialise in critical care, and I'm joined by three fantastic speakers who are all going to talk about their cases and their experience of phagenics. We have with us today Rachel Coates, who is a clinical specialist SLT in stroke at the Mater Hospital. And we have got Ben Lawrence Owen, who specialises as team lead medical and neuro at Chesterfield Hospital. And we also have Elizabeth Fraser, who is a clinical specialist stroke lead at Wickham Hospital. So it's a great pleasure to have you. Thank you for taking time out of your really, really busy day. And we're going to talk about dysphagia rehab using pharyngeal electrical stimulation. These are our speakers, and I'm going to start by basically giving you some background to phagenics, where PES fits into treatment, when it's useful, how it developed, how you use it, how it works, and then I'm going to talk about research as well. And I'm going to finish my bit with some of my data from Wythenshawe, and then each of our three speakers is then going to give a case presentation. So let's start thinking about clinical treatment options for dysphagia. So we know that we've got various tools at our disposal where we can use different things to treat motor impairment with, for example, dysphagia exercises, EMST, using oral tastes to really stimulate strong swallows. But I think the problem is often that we're not treating the underlying sensory problem. So it's quite difficult to get a stronger swallow if there's no swallow being triggered in the first place. And this, I think that the trouble of trying to treat sensory impairment is that we don't have very many options. And this is obviously where phagenics fits in. So if your patients have tracheostomy, for instance, and obviously I work a lot with trachea patients in ICU in particular, one of the things that we really need to do early on is restore airflow. And we do that by various techniques like cuff deflation, using a one-way valve, if they're ventilated, a Passy-Muir valve. And we can use other techniques like above cuff vocalization when the cuff is inflated, or when they're transitioning cuff deflation. And we can also change the tube if we need to try to promote more airflow. We don't really know what airflow does, but we do know that it seems to stimulate swallows, and there's a lot to be learned still in that area. But really, airflow is about sensory stimulation as well. But if your patient doesn't have a tracheostomy, what do? We still have a gap in terms of how do we treat the sensory aspects of a dysphagia. We also do a lot, don't we, in dysphagia management to provide supportive strategies with patient education, for example, and enlisting compliance and insight. And we also have an option sometimes to use medications because a patient may have reflux or edema, and those things impair both movement and sensation as well. But I think the key thing is that pharyngeal electrical stimulation presents another option for us, and a kind of revolutionary treatment as far as I'm concerned, in terms of directly stimulating the afferent aspects of swallow. So I'm going to talk about where it came from, first of all, because it's been a pretty slow uptake in the UK. This treatment was actually founded back in 2007. There's been over 25 years of research to support the development of this treatment, largely carried out by Professor Shaheen Hamdi and his team in Manchester. And he's done phenomenal work to increase our understanding of swallow control and dysphagia, basically since the 90s. And this research culminated in the development of this device that we use today. And it was actually CE marked and approved for use back in 2012. So I think it's been difficult to implement and slow. There's been slow uptake in the UK, but when you look at the outcomes and the evidence, it doesn't fit because the outcomes are quite marked, and we really can make a big impact with this treatment, and the cost benefits can be quite huge. It's not designed for patients with progressive neurogenic dysphagia, just to say that out up front now. It's been proven to be safe and effective, and that's one of the things to make sure people understand if you're thinking of trying to use and implement phagenics, is that it's not an experimental treatment. It's a class 2 device. It's had breakthrough device designation, and it's actually been FDA approved in the States now and is starting to be used over there. So how does it work? Well, we know that when there's a neurogenic etiology to the dysphagia, there's damage and disruption to the neurological swallowing control, and this results in an impaired swallow. This damage can be central or peripheral. If it's central injury, this is what we mean by someone who's had a stroke or a head injury, for example, and there's interference with the processing of the sensory information that's generated through the afferent signals and the sensory receptors, the proprioceptive receptors, the taste receptors, pressure receptors in the laryngopharynx. And obviously, we commonly see damage to the brainstem directly when we have brain injury or stroke. But we also have lots of patients where there's peripheral injury, and this is kind of more what I'm used to seeing in my critical care caseload, although I do see patients with stroke and other direct central injury. But with peripheral injury, this can occur when there's sort of mechanical damage or desensitization. So for instance, when a patient has got an endotracheal tube or a tracheostomy tube and the cuff is inflated for some period of time, and we get muscle atrophy and we get oropharyngeal nerve atrophy in cases where, for instance, patients been intubated. And what this does is it impairs that afferent nerve signal still, but in a different way. It's a different mechanism. But the outcome is that they still have a problem initiating a swallow and a problem with sensation, which leads to problems like silent aspiration. And if you don't have that urge to swallow or that afferent trigger, then your swallow is no point trying to treat the strength of a swallow if you can't even get a swallow in the first place. So this is why we need to treat the underlying sensory issues first or concurrently with the motor impairments that we see. So PES provides stimulation to the sensory nerves through the use of a catheter. And when you connect the catheter to the base station, it's the intensity that you deliver is very patient specific, and every time you deliver the treatment, the thresholds are set. And what happens is that those signals then excite both the damaged and the undamaged cortex, the motor cortex. And this has been shown through the research done by Professor Handy with PET scans and MR scans. And that excitation in the motor cortex is what drives the neuroplastic functional reorganization of swallow control. So it's restoring that integrity and providing the efferent signal that you need to actually produce a swallow. From the higher brain to the brainstem to the swallow reflex. And what we also see is this increase in neurotransmitter substance P. And that's a substance that we see when somebody has an active swallow. So we've shown again in studies that an increase in substance P occurs through this treatment. So that's a good thing. So this is what the system actually looks like. So you have a base station And the software is actually very simple to use, and it takes you through the procedure every single time, with allowing you to set the individualized thresholds to capture your data and to store the data. And it also captures the patient treatment and specific thresholds that you're delivering. So it's really, really helpful for outcomes and measuring your outcomes and measuring progress as you provide each individual treatment through the week. And the catheter is a modified NG tube. You can use the tube for delivering feeding and nasogastric feeding. So it's simply a matter of swapping this tube for the NG tube that's already there. And there are markers on the tube to help you sight the tube and keep it in the optimal position. So, and the fit, just to say, the fit on the tube is a standard end fit for the enteral feed connection to the pumps. And it's really important that the electrodes are in the right position so that the treatments are delivered correctly. And as I say, there's markers on the outside of the tube, and in the oral cavity, you can visualize green stripes around the tube just to do a check before you start any treatment. And I think you can see that here on this slide, the green markers that you should be able to see if your patient opens their mouth, and the black markers at the front of the nose that help you to see that the catheter is in the right place. And the electrodes are around the tube at about position C3, C4. And what it does when you connect it, delivering 10 minutes of treatment, is kind of providing what we call a safe super bolus. So it's acting on the pharyngeal and laryngeal mucosa, and that is a field, electrical field, that is extending in all directions. And clearly it's targeting the nerves that we know are so important for swallowing and for the sensory aspects of the swallow, including the glossopharyngeal, the vagus, and all the different branches that help us to move the larynx and to, move the base of tongue and trigger that motor swallow response. So patient selection is something that's, obviously key, as it is with deciding about any treatment for dysphagia management. And one of the key things here with phagenics is, for me, is using it when a patient has really, really severe dysphagia. So often we will know from a bedside assessment and confirm from an instrumental assessment, such as fees or videophroscopy, that there is a sensory impairment going on. There'll be reduced or no spontaneous swallowing. There'll be poor sensation, and that's, indicated by symptoms of silent penetration and aspiration, infrequent swallow responses, and lack of or poor cough response. So all of those are indicators and symptoms of a sensory impairment, aren't they? And included in that as well is residue and lack of response to bolus stasis in the pharynx, and that could be saliva or liquids or food, and no spontaneous clearance of that. So I think the patient selection is really all about understanding your patient's dysphagia in detail, and then highlighting and detecting that there's a large sensory aspect to that dysphagia, and then this is the treatment that might help. So the only caveat and the only exclusion criteria for this treatment, because it involves electrodes, is you must not use it in patients who have an implantable electrical device or need to go to MR scan. Also, it's not for pediatric patients or for pregnant women. So other than that, it's suitable for all patients. There are certain patient groups where we're not clear exactly the impact of phagenics, for instance, in head and neck patients yet, because we haven't got enough data. But that's what's exciting about this treatment, is that there was still a lot of areas where we can actually, really, really look at specific impact and specific patient guidelines, I suppose. So NICE have produced what's called an interventional procedure guidance document back in January this year. So this is not a NICE guideline as such. So it's not, it doesn't have the strength of a NICE guideline, but it is something that we need to be aware of and something that we need to think about, because at the moment what it's saying is, having considered the evidence that we have and the research that we have, that undoubtedly treatment is safe in all the populations that have been treated. NICE recognise that there's an absence of sensory dysphagia treatments available, as I've been talking about. And they actually recommend it now for people with neurogenic dysphagia who have a tracheostomy after stroke. So that's a fairly strong statement. And I think that means that, it is something that people need to be trying to implement into their service and practice. For other patients who may have a stroke but not a tracheostomy, or haven't had a stroke but have other causes of neurogenic dysphagia, so for instance generally my patients in ICU who have more of a peripheral problem, we can still use the treatment, but we must collect data and we must build the evidence base. So it's really important that we do this in a robust way, and that we are aware that we need to be collecting data in order to expand the use of this treatment across other populations. So in terms of side effects, there's not much to worry about, really. There's nothing major at all. What we've seen are a few rare minor side effects that have been seen during the treatment. So one of the things is patients experiencing a little bit of face or ear pain during the stimulation itself, or jaw chattering. So it might be a matter, therefore, of you adjusting the catheter a little bit further in, just to slightly alter the position away from the stimulation of the nerves, and just drop the level a little bit, perhaps, just to take the edge off that. Or if it's really bad, obviously you would stop the treatment. Another thing that actually has been observed, I think, again, rarely, is some arytenoid edema, which was seen on the follow-up fees, post-phagenics, and pharyngeal abscess. Now, I think this is incredibly rare. It's hard to tell whether there's an association or relation to the treatment itself. It could be that this was happening anyway. Certainly in my patient group, edema is something that happens very frequently and can be remitting and relapsing and fairly intermittent. So nevertheless, it's important to note if you see issues when you're delivering treatment, to log it, and to, I think, remove the catheter if it seems to be a problem, and complete, finish the treatment and replace it with a standard tube. Another thing that has been reported is hypersalivation. Obviously, this isn't harmful. You can suction to remove saliva. I think one of the things is, if you're stimulating the swallow when you deliver the treatment, is that you're going to alter the secretion management and change the saliva control, awareness. Hopefully the patient's becoming more aware of the need to swallow. So to me, it's not a reason to stop treatment. It's something to explain to your patient and sort of manage at the time. So just to talk a little bit about the foundational research, as I said, Professor Shaheen Hamdi in Salford in Manchester has done incredible work, really, which has increased our understanding widely of the neurogenic swallow control. So the study in Nature was the first to map the swallow motor cortex, both in healthy and in disease processes as well. We've also been the first to show functional reorganization of the swallow in the motor cortex in dysphagia. And again, a first to show the long-term cortical reorganization, which was driven by the short-term sensory stimulation that is carried out in this treatment. And further than that, demonstrated that the sensory stimulation driven reorganization did actually result in functional swallow recovery. Because at the end of the day, what matters to the patient is that there's a functional change, and that that means that they couldn't eat before, they can eat now. So the whole purpose of our treatment is around giving patients better quality of life and functional benefit. And this has been demonstrated. And there's a whole raft of studies here which, if you're working with patients following stroke or TBI, that have shown improvements to swallow timing, to airway safety, to diet and fluid independence, removal of feeding tubes, and subsequently reduced length of stay. You'll notice from the outcome measures that a range of tools have been used. And obviously instrumental assessment is really important for showing sort of accurately demonstrated outcome measures, outcomes that are different and change and benefit. But in addition, we do need the functional measures that look at how much supervision the patient might need over a meal, or their dependence on feeding tubes. And that's where we have things like the dysphagia severity scale and the functional oral intake scale. So it's not exclusive. I think we need to look at using as many outcome measures as we can in dysphagia as a rule. And also in particular, if you're trying to demonstrate whether pharyngeal electrical stimulation has made a difference in your service to your patients. So lots of publications you can look up. And then a whole bunch of papers here that have looked at non-CNS injury patients that have shown, and including COVID as well, that have shown benefits, as I said, to things like increased substance P, which indicates more swallowing activity, improvements to secretion management, airway safety, less need for re-intubation, rapid and successful decannulation, reduced pneumonia rates, improved diet and nutritional independence, and reduced length of stay, because that's obviously a metric that will occur when you improve all the other things. And that's in patients who've been and undergone prolonged mechanical ventilation. So there's a lot there that we can use, and you can see from here that the research has been gathering momentum, I suppose, since 2002 up to the last couple of years. And there's a number of RCTs in there as well, in some very high impact peer-reviewed journals such as the Lancet. So I think if you're trying to convince your service that this is a good idea, I think you can sort of throw this kind of thing at them and say, look, this is not something that is off the cuff. This is a there's a good strong foundation, really, and probably a stronger foundation than a lot of the treatments that we currently use in dysphagia, that don't necessarily have this degree of evidence behind them, such as some of our swallowing exercises. So just to finish, I'm going to tell you a little bit about our experience at Wythenshawe. And I started to think about using Phagenics back in 2017, when I guess I was driven by frustration with sometimes the lack of progress in some of my patients in intensive care, that despite other techniques like airflow and exercises, when still very dysphagic, and really feeling like I need something that will really treat the sensory problem. So with the support of Phagenesis, I was able to trial Phagenics in the ICU patients, just as a bit of background, the hospital is 1,000 beds. We've got approximately 55 to 60 critical care beds, mixed populations. And I decided right from the start that I was going to collect accurate data as well as be as accurate as I could. So FEES was performed in order to select a patient for the treatment, and then FEES was performed post PES, as a routine, so that I have direct comparisons with all the normal FEES rating scales that we use. So of 19 patients that I'm going to present the data on here, 17 of them had a tracheostomy at the time. One died, that left 18. And the mean age of the patients was 64, which is approximately the mean age for patients in intensive care. So you can see from this slide that presents the penetration aspiration scale scores. The blue is the rating pre-phagenics from the FEES, and the red is the rating after approximately 4 to 5 treatments of 10 minutes a day. So I think you can see that everyone bar one patient was nil by mouth at the beginning due to silent aspiration, and 11 out of the 18 patients that survived actually progressed, and some of them making fairly large improvements to having sort of normal swallow. And in terms of IDSI levels and the patient's ability to actually commence oral intake, again, the blue is pre-PES and the red is post. And you can see again that there's a big change and improvement seen in 16 out of 18 patients, and some of them like pretty dramatic, going on to sort of normal diet, normal fluids. And that's over the course of a working week. And these were patients that had been as medically stable, dysphagic, not progressing. So for me, there was a sort of real acceleration in improvement beyond spontaneous recovery, because it was rapid. So that brings me to the end of my presentation, and I'm going to hand over now to Rachel, who's going to show us her case and talk through what she found when she used PES.
Hi, thanks for that, Sarah. That was a really comprehensive overview. So like Sarah said, my name's Rachel. I'm a speech and language therapist at the Mater Hospital in Dublin. So yeah, you can see the slide. So I'm going to present the case of the first patient we treated using pharyngeal electrical stimulation at the Mater in November last year. So this is Brian. He's a 57-year-old male, previously fit and well with a history of hypertension and sciatica. He was admitted to the Mater in September with a query stroke. His wife heard a loud noise and then rushed down to find him lying face down on the floor with left-sided facial droop and left arm and leg weakness. She called an ambulance and he was brought in as a fast call. So a CT angiogram showed a large intracranial hemorrhage secondary to a right MCA aneurysm rupture. After imaging, he was immediately transferred to Dublin's neurosurgical hospital for coiling of the aneurysm. He had an eventful 3 weeks with a prolonged ICU stay and intubation due to cerebral vasospasm, low GCS, recurrent aspiration pneumonias, and respiratory sepsis. Then on the 12th of October, he was medically stable and was transferred back to the Mater under the stroke team, although within 2 weeks he was re-intubated for a VATS procedure for empyema and had another short stay on ICU. For a period of several weeks, he remained too unwell for SLT assessment with fluctuating GCS and high secretion burden. Early in November, the option of PEG was considered during an MDT meeting, as at that point he'd been nil by mouth for 7 weeks. It was decided to allow a little more time as he was beginning to show signs of general clinical improvement. On the 14th of November, he had his initial FEES assessment. This confirmed the bedside assessment findings of a severe sensory motor dysphagia, and it was characterized by delayed initiation, pre and post swallow silent aspiration, and moderate to severe residues. His PAS score was 8 on both the level 2 and level 4 fluids and diet, which were the only consistencies trialed due to the high risk of aspiration. So at the time, we didn't have PES available as a therapy option, and no other acute hospitals in Ireland were using it. I had some experience of using PES in the UK, and I felt he would be an ideal candidate. So we expedited our order of an evaluation pack from Phargenesis. In the meantime, we commenced traditional therapy, including ice chips to aid secretion management and practice swallowing, EMST to promote airway protection and cough effectiveness, and also utilising strong flavours for sensory stimulation. There was no significant change in his swallow presentation at bedside prior to commencing PES, although a further instrumental assessment was not conducted immediately prior to the treatment. So fortunately, the PES equipment arrived within 2 weeks and we were able to begin treatment on the 29th of November. So it's worth noting there is some training involved, but we were able to get started straight away as myself and another SLT colleague were already trained. So during each treatment session, we observed him to trigger continuous swallows of his saliva for the entire 10-minute duration, which is something we'd rarely seen pre-treatment. His tolerance of the stimulation reduced over the 3 days, and this is another positive indication of some restoration of sensation. And he also reported being able to feel the catheter in his throat after day 2. The catheter actually fell out after the 3rd day of treatment, which was one complete cycle. We had been considering another treatment cycle, but were unable to complete this. So we now bridle the catheters to avoid this happening. So we waited a few days to repeat his fees. So I'd learned in the past that the full effects of the treatment can be delayed. So there's nothing to be gained from doing a repeat instrumental immediately after a treatment cycle. So his previously severe dysphagia had almost fully resolved, and he was able to safely commence level 0 thin fluids and level 6 soft and bite-sized diet. His PAS scores were 1 on all consistencies trialed. He was absolutely delighted with the outcome of the treatment, and his wife was able to bring in cake for his birthday a few days later. And he also avoided having a peg tube inserted. And then after a few weeks of treatment targeting the oral phase and base of tongue retraction, he was upgraded to normal diet on a bedside assessment. So Brian is now back home, having made a full recovery, and is planning to return to work in August. So we collect quantitative data on the outcomes of all of our PES patients, the functional oral intake scale, PAS scores and things like that. But I also like to collect some qualitative data. So this is what Brian had to say. So he said, I haven't had a thing to eat or drink for 9 weeks. My tongue was stuck to the top of my mouth. I'm over the moon to be able to have a cup of water. I can't wait to have a bottle of Coke in my hand. It means everything to have my swallow back. It's like a lot of things in life, you don't miss it until it's gone. I certainly didn't see myself eating and drinking this side of Christmas. I know I didn't like the treatment, but I definitely recommend it. It's worth it in the end. So that's my case study. So I'm going to hand you over to Ben.
My name's Ben. I'm a speech therapist at Chesterfield Royal Hospital, and I work on our critical care unit and the other wards as well. There's We've got a 15-bed unit at Chesterfield with a mixture of patients on there. I'm presenting on a 35-year-old female who had a pontine hemorrhage due to cavernoma on the 2nd of July in 2023. So her background is she'd had a previous pontine hemorrhage due to a cavernoma in 2019 on the other side. And she had some dysarthria and some palatopharyngo-laryngomyoclonus, which is basically like hiccups in the back of her throat. We didn't actually know about that until we did the fees with her later on in her stay. She had some dysphonia from that and dysphagia from the previous cavernoma, but she was on normal fluids and normal diet, easy to choose normal diet prior to the new cavernoma. So she had the hemorrhage on the 2nd of July and an evacuation in Sheffield, which is our local sort of neurosurgery hospital, and repatriated to Chesterfield with a tracheostomy and low GCS on the 28th of July. So we saw her and she had a size 8 tracheostomy at this time with her cuff up, lots of secretions in the subglottic port, no voice on above cuff vocalization, and with a Passy-Muir valve trial, very gurgly and weak voice, wet voice with lots of secretions. We used IOP to measure her tongue strength at this point, and her anterior, so tongue tip, pressing to the tongue tip, was 4 kilopascals. Normally it should be in around 50, and posterior she couldn't get a measurement at all, so she's very, very weak. On the 2nd of August, she was downsized to a size 7 cuff trachea, and she had some more time with the Passy-Muir valve. So we're trying more traditional therapies there. She developed a chest infection with this because she's having more time with the cuff down, query and aspiration pneumonia. So we did a FEES with her on the 17th of August, and you can see the image on the left-hand side there when we tried her with a bolus. So she did no spontaneous saliva swallows or clearing swallows for that residue that you can see pooling in the piriforms and in the airway. So she was a PAS of 7, so she was coughing to respond to that, but unable to clear it with any clearing swallows. So we obviously didn't have PES in our hospital at that point. I actually got in touch with Sarah to try and get some supervision and help with this patient, and she recommended Phagenics as a treatment option. So I managed to get in touch with Bex, and so that was on the Thursday, and by the Monday we were able to start the treatment with the patient. So it's a really quick turnaround. So we commenced on the 21st of August. So it's day 50 after her event, and she had 6 treatments completed over 8 days. And you can see on the threshold column, which is how sensitive she was to the electrical stimulation, that on the first day that reduced from the second. So she was detecting it at 29, and then by the second day it gone down to 11. So it just shows that it resensitized her pharynx that quickly. We did a FEES on the 31st of August, so 2 days after her final treatment. Now, we did notice a retinoid edema, which was Sarah mentioned earlier as a potential quite rare side effect. As to whether that was due to the PES, or she also had reflux, it could have been related to that. But the main thing was that she was starting to do spontaneous saliva swallows and clearing her secretions, which was the big problem for getting her decannulated. She was still aspirating overtly with level 0, level 1, level 2, but she didn't aspirate with level 4, and there's a lot less secretions, as you can see on the image on the right hand side. Secretions pooling her piriforms were a lot less. So we recommended level 4 trials and considered to be suitable for the cannulation. So she was decannulated the next day. That meant she was able to be transferred to the stroke unit, which is a much cheaper bed for the hospital. And then she was upgraded at bedside to a level 2 and level 4 the following week. And over the next few months, she was upgraded to level 1. And then she decided she'd had enough thickener and wanted to eat and drink at risk on level 0. But the main thing is she didn't have any adverse signs with that. She wasn't having any chest infections. And so she was discharged home with no chest concerns. I think on the next slide, I think we have a quote from her. So the outcome at the end of the treatment was the most positive aspect. I was nil by mouth, and now I don't stop eating. So I'll just, that's me. I'll pass on to Libby. I think he's going to.
Thank you, Ben. Yeah, my name's Libby Fraser. I'm a speech and language therapist based at Wickham in sunny Buckinghamshire, predominantly on the stroke unit, but also venture into intensive care when needed. We have been using Phagenics since autumn of last year, and I wanted to present a case that we had quite early on into that time. She is a 36-year-old female, a young working mum with a 2-year-old. She went to see a chiropractor who did some work on her neck, and then a couple of days later she woke up unable to swallow. She came into our CSRU here and was found to have had bilateral vertebral artery dissection and left lateral medullary stroke. Her only real symptom of the stroke was not being able to swallow, and she literally had no swallow. She was sitting in a bed with a Yankee suction tube taking away her secretions. She would have been discharged quite quickly had she been able to swallow, because she would have been able to go home with early supported discharge probably within a couple of days. But obviously she was kept in hospital. She had an NG tube, and this Yankee suction taking away all the secretions. So we carried out a FEES on the 6th. So she was admitted, oh, I didn't say that, 25th of November 2023. So we carried out a FEES on the 6th of December, which you can see the first picture there. She just had lots of really thick, I think she had a chest infection at this time. She had really thick, creamy secretions throughout the larynx. She had no swallow. She was not sensate to the scope at all. We couldn't get her to trigger a swallow voluntarily. She was coughing on secretions, but also she wasn't always aware of secretions. So she'd talk through, she'd have a wet, gurgly voice and not be aware that she needed to clear. So that started us thinking about the sensory side of things. At that phase, we didn't try bolus because we felt it wasn't safe. So I quite quickly got on the phone to Bex. As Sarah said, patient selection is very, very important. Talked through the case with Bex. She said, yeah, absolutely, let's go for it. And so we commenced our treatment on the 12th of December, which was 17 days post admission. And we did 6 back-to-back treatments. So one of my colleagues came in over the weekend and administered the treatment because this lady was desperate to get home for Christmas to her 2-year-old. So we were all desperate to make that happen. I'm not going to talk much about her thresholds and tolerance because she tolerated 50 milliamps every session because she was a fighter and she wanted this treatment to work. And you could see that she was feeling it, but she absolutely kept us going to the very max of the tolerance that she would take. This was an early, as I said, this was an early treatment that we did. And similar to Rachel's case, we have found since then that 4 days post PES is a good time to do the FEES. But we did it 2 days in the early days. And actually there was some improvement. So she was swallowing. And I would say that during the treatments, she was swallowing all the time. That swallow was really there. So the 2 days post PES FEES did show some improvement. She was able to clear secretions. We were able to try bolus. She did have a PAS score of 4 with level 2 sips. We tried a little bit of yogurt that was only a PAS of 1, which we were quite pleased with. So we decided to start her off on having just restricted amounts of yogurt just to try and build some strength. And she still felt she wanted suction, so she still felt she wasn't managing her secretions very well. So that was the 19th of December. She went home on the 19th of December for a home visit to see her son. And we'd set up home suction and all the rest of it. And she came back in after that saying she hadn't needed to use the suction and she'd been having little bits of the top of a trifle and bits of custard. Her and her son were sharing petit filous. And then I was in the Bay on the 21st of December because we were planning just to sort of start upgrading at bedside as and when. On the 21st of December, seeing another patient, and she called me over and she said, I can't cope with this NG tube. You have to get this NG tube out. She said it was all she could feel. The sensation of it was just intolerable. And I was really excited because that's something that we see quite often at the end of our PES treatments, that the patients who before were quite happily sitting there with an NG tube in, not aware of it at all, they then can't tolerate the NG tube. And it's a great sign because it shows that sensation is back. So we got the FEES stack up and said we'd have another look. And you can see from the image on the third image, she had a normal larynx. I mean, she had a normal swallow. It was just, all of us were sort of standing around looking at it. And she said to us, you guys have to start working on your poker face because we were just, so we removed the NG tube before we did the FEES actually, because she just couldn't tolerate it. She basically was great with everything. She was a PAS score of 1 on everything we trialed her with. She fatigued a bit by the time we got to biscuit, but this was a really long session that we had with her. And I think, she hadn't really been eating or drinking anything prior to this. So we recommended level 6 and level 1. And she went home. She went home that day for Christmas with her 2-year-old. And I remember talking to Bex afterwards. And she said, why did you not put her on regular diet thin fluids? And I was like, well, I've been working 20 years and I have never in my career taken somebody from being nil by mouth for over a month to level 7, level 0, and discharged them on the same day. I was too scared to do that. But my confidence has massively grown since using PES. If I were to do that case again, I would have sent her home on regular diet and thin fluids. She did have a vocal full palsy, which we referred to our specialist voice service, and that has since resolved. I had said to her, when she goes home, try a little bit of regular food. She knew her swallow really well by this point. She was so in touch with it. And yeah, that was a great success. On the next slide is some of her feedback, I think, Sarah. Basically, she said that, you know, her belief was that PES really facilitated her discharge from hospital. And, you know, she was a young mum with a young child, and she just wanted to get out of hospital. And then she did sort of talk about the team who held her hand and supported her. And it is 10-minute sessions, 6 10-minute sessions. And my team tried to make those sessions as fun as possible. So we take in music, we're all singing, we're all being silly, just to take people's mind off it. And they are actually really lovely sessions and a really lovely outcome.
Wow, amazing. Thank you so much, Libby. I think I'll just make a few points. I think what comes across so powerfully is not just the patient benefit, but actually how it feels as the therapist to have such impressive outcomes with a patient that you've been sort of scratching your head and you know, really concerned about and trying everything. And then something like PES just seems to switch things back on much quicker. And I think I've had moments like you say, which is where you just can't believe what you're seeing when you're doing that final fees, and you just sort of having to pinch yourself because you're thinking, how is this such a dramatic improvement? But I think, yeah, I think that's you know, it's all the cases have shown just what a difference this treatment can make for some of our patients. Clearly, it's safe. I think it increases our efficiency because it does seem to sort of expedite recovery in, you know, in selected patients. And I think yeah, the impact is huge for not much effort. As you said, Libby, 10 minutes a day is a pretty quick thing to do. And also you can train other members of the team to do it. And you know, we can train other people to do it. You know, it's not difficult treatment to deliver. So I think in terms of promoting recovery, promoting early decannulation, improving swallow safety, there's evidence and there's clinical anecdotal evidence, but data is important, and it's brilliant that you're all collecting data and using that to, you know, improve the way you're using this and to show and demonstrate the value of speech therapy and the treatment to others in the MDT as well. And yeah, I think that last point there about filling a void is how I felt right from the beginning, and it has borne out in my experience, and I think you're finding that too in your experience. So I'd like to thank all our speakers. The contact details are all there on the slides that you can check later, and there's also loads of references at the bottom of the slides, which I won't look at now. I'm going to stop sharing my screen and bring us all back for discussion. So thank you very much for presenting all your cases. If you wouldn't mind or putting on your, switching on your microphones, there's some questions that have actually come in. So I'm going to choose a couple for us to discuss, if that's okay. So would you all mind commenting on whether or not you think it's necessary to have an instrumental assessment to be able to do this treatment? How important is it that there's an instrumental assessment first? Anybody?
Okay, so at the Mater, we always do a pre and post instrumental. We are lucky in that we have very good access to fees and video fluoroscopy. But I'm trying to think, if I was working in a setting without instrumental assessment, I don't think I'd want to deny a patient access to this treatment purely because of the lack of instrumental assessment. I think I'd be hopefully putting in a business case for both instrumental assessments and
Yeah.
for PES.
Yeah. And anybody else want to add to Rachel's point?
I agree with Rachel, actually. I mean, we're very lucky that we do have fees. We don't have VF, we do have fees. But 100% agree that I would, with the changes I've seen and the difference I've made it seen to patients' lives, I would not want to deprive anyone from using the treatment.
Yeah. Ben, you want to add anything?
Yeah, I guess in our we don't have fees fully signed off in our hospital yet, so we did a bit of a makeshift ENT using our scope equipment. We've got the equipment, but not necessarily everything set up. So fees, so ENT did the scoping, we did the analysis, and we got a bit of help from Sarah along the way. So we were able to make it work in not an ideal setup. So it is possible, but I think without the instrumental, you need to make sure you're definitely treating the right thing and that there's not a structural impairment, for instance, that's causing the main issue.
Yeah, and I think I agree with all of you. I think that if you're working in a situation without any access to instrumental, then that is a problem in itself for dysphagia treatment, because it's very difficult to tailor treatment, isn't it? But I think there are obviously clinical signs of sensory impairment that are detectable on a bedside clinical exam, and that you should still offer it if you can, because we offer other treatments in those scenarios. So why would you not offer this one, as long as there's no clear exclusion? So yeah, I think it's clearly a problem in the current climate that some people are struggling to access all of the resources they need. But I think you just have to fight. We have to fight for everything and be proactive. And like you've shown there, Ben, your ways around the problem of having, ready access to a responsive fee service is to sort of find other ways and be sort of innovative. So yeah, I think that's the best approach, isn't it? Another question then, guys: who places the catheters?
So in our trust, it is the nursing staff who place the catheters. Obviously we work on a stroke unit, so our nurses are very experienced in placing NG tubes. And Bex came in originally to do the training and trained a couple of the nurses, walked them through how to place the catheters. So they are quite good at that now.
Yeah. Where I work, either the doctors or the nurses, whoever's trained to insert NG tubes, inserts the catheter. I always go along for the insertion and just kind of explain a little bit about kind of how the catheter is a little bit different, explain it's a little bit more rigid than a normal NG tube. And I kind of help them with the NEX measurement and making sure that we have the green rings in visible in the oropharynx, just to make sure it goes as smoothly as possible.
Yep. Ben,
So,
how does it work for you?
Yeah, it's doctors or nurses, because but it's only the critical care doctors or nurses if they've got tracheostomy, in which they do obviously for this treatment. So yeah, it's doctors or nurses.
So we have also trained our ACCPs, our advanced critical care practitioners, to pass the catheter, and also it's an option for level 3 fees trained speech therapists to be trained to pass the NG. My team were trained to do NG passage during the pandemic, and so as long as you maintain your competencies, you can pass the catheter yourself if you have that agreed in your trust and the appropriate governance. So level 3 fees training, it's like passing a scope, passing an NG. So I think that's another option for people if they haven't got, access to trained staff willing to sort of support inserting the PES catheter, but I'm sure most people can persuade them.
Yeah. Also, just to add, it doesn't need to be used as a feeding tube. If a patient has a PEG and they're kind of very long way down the line, you can insert it purely as a treatment device rather than using it as the dual purpose as an NG tube.
Yeah. And have you done that, Rachel?
I haven't personally, because I've been doing it kind of in more acute stages, but I know other places where patients have been maybe home for 6 months to a year and then come in for the treatment with a peg
Yeah.
incision.
We have done that once. It's just a matter of, I think, persuading the patient that having an NG back in is is worth a shot, if you see what I mean, because this is, as you say, it's just for the treatment only. So it's dependent on the patient's acceptance of that. But yeah, we it's a good point. Thank you for raising that. So training. What training did you get for doing this treatment, and was it difficult? And how much was it? Was it free? What happened? What's your experiences?
So my understanding is, well, the training is like included by the company kind of on the purchase of the device and the catheters. And they've been excellent at coming whenever we've needed training. So there's a theory component and then a practical, but I'm sure Bex will be able to provide kind of more detail on that.
Yeah, and just to say that the Bex and Lauren in the UK who do provide the training are both specialist SLTs, so they understand our issues. So is that what happened with you as well, Ben and Libby?
Yeah, I mean, we had a couple of visits from Bex over a sort of a 6-month period, and my entire team is now trained, right from myself down to our band 5. So everybody is trained and able to do it. We tried to, because obviously we were on a corporate caseload in our stroke unit, so everybody sort of sees everybody. But when we're running a Phygenics treatment, we try to make sure that there's one consistent member of staff who is running the treatment, but then we all sort of tag team in and out, so we're maintaining our competencies and our practice at doing it. I think that consistent member of staff is quite useful for when you're sort of setting the thresholds and everything, and you're looking at the same things. But yeah, the training was really straightforward and quick, and Bex seems to be always around, so she'll be visiting neighbouring hospitals and she'll drop us a line and say, do you need anything? I'm here. So they've been really, really supportive, and always at the end of the phone to discuss a patient. And as you said, the patient selection is so important, and we want to get it right because we want to use the equipment right. We want to make the most of it and get the right patient and the right result. So they're always happy to talk through a patient and say, do you think this is the right sort of patient? And that's been invaluable.
Yeah, that's really important. Ben, have you got anything to add?
No, I'd echo the same. Yeah, I can't add much more to that.
So I think your point again about having everyone in the team trained is really good, because that's how we've done it as well. Is when we've had new staff in, like Bex has been recently again to train up the sort of newer members of our team, so that I think it's great experience for the band 5s and band 6s to deliver this treatment. And like you say, I think that oversight by somebody, perhaps the fees trained person or whoever did the initial assessment, is vital, and the collection of the data is vital. I think one thing I wanted to ask you guys, because this is what I observe sometimes, is that the thresholds change. The first time you do the treatment with the patient, they're obviously a little bit nervous. They've obviously got sensory impairment, but you can tend to push the threshold higher on the second treatment.
Yeah.
Because they tend to be a little bit nervous. They don't know what it's going to feel like. All those techniques you were talking about, distracting a patient, telling jokes, looking at a paper or whatever, help the patient to sort of take the mind off what's happening. But second treatment, you can usually whack it up a bit higher. Is that what you find?
100%. Yeah, I agree.
Yeah.
And I asked the patient how it feels. Do you ever ask them how it feels? I've had some really interesting answers.
Yeah,
Have you
I've had people describe it as like tiny little pinpricks. And some patients just describe it as kind of vibrations in their throat, but I would love to know what it feels like.
So you can actually see it vibrating and feel it vibrating, can't you, as well sometimes?
And the amazing thing for me was just seeing continuous swallows. Like there was one patient, and during the first session, I was actually counting the number of swallows, and we got to 90 swallows in 10 minutes. It's like, who swallows 90 times in 10 minutes?
From
So
zero before, presumably.
yeah,
Or, yeah.
so
Yeah.
Yeah, I got to echo that as well with our patient, that you'd sit at her bedside with the cuff down, the passenger valve on, and not see a single swallow, and think, "Oh, we're never going to get this trachea out." And then in the treatments, seeing 90 to we saw similar numbers of swallows in 10 minutes.
Mm.
It was amazing.
Yeah,
And that's when you
that
think, and
happened
I
to me
thought,
with
oh,
my
this might actually work.
yeah, that happened to me with my first patient, and because it was my first patient, my mind was blown actually. So I was like, "How is this happening? How have we gone from 0 to 90?"
yeah.
um,
It's also worth mentioning that you can kind of recalibrate the number of milliamps that are being delivered. So obviously when you're calibrating it initially, it gives the patient an 8-second kind of sample of this is what it's going to feel like. Can you tolerate that for 10 minutes? And they can say
yeah,
yes or no. But even if you go ahead with the particular kind of amount that's been decided by the machine, if like 30 seconds in, the patient's really struggling to tolerate it, you can either pause, give them a break, do some mouth care, and then restart, or you can restart the whole kind of calibration again.
yeah,
So you don't want the patient to be sat there in agony, traumatized by it. You can recalibrate.
that's a
Yeah,
great point, Rachel. Thank you. Sorry, Libby, did you want to say something?
yeah. I was just going to say the patient that I presented today, she said that it was like there were tiny men with pickaxes in her throat, sort of trying to chip their way out, but not in a like excruciating, painful way, just in quite an odd prickling sensation. And similar to Rachel, what she was saying, we recently did the treatment on a chap with a trachea, and he needed regular breaks during each treatment, even though it was 10 minutes, particularly the first one, because he started retching, and he retched a lot anyway. He retched during physio, he retched during suction, he just retched a lot. And I was a bit worried that he might vomit, so we gave him a bit of a break for sort of 20-30 seconds and then restarted. During the treatments, his breaks got less, so he required fewer breaks. I think there was still a bit of a behavioural element to him because of the issues he was having, and we didn't think it had worked. We thought it's not going to work. It was a bit
Yeah.
of a long shot. We did the final fees, and I literally had to leave the session with my team in there doing the fees, and I had to run out of the hospital trying to find some porridge because he was doing so well that we'd taken a little bit of yogurt and a little bit of thin fluid, nothing else. And they were like, go and get some porridge, and I was running around the hospital trying to find porridge because he did so much better. And he was decannulated a few days after that, when we'd actually been planning for him to have a long-term trachea and go to a nursing home. So
Oh my God, that's
amazing
massive, isn't
outcome. Yeah.
it? Amazing. And I don't think this is unusual. I think, I've been using it for years, and I see these dramatic sort of everything turns upside down suddenly in the care. So the plans for PEG, the plans for long-term trachea, the plans for, difficult rehab placement with a trachea or nursing home, or suddenly isn't needed,
Yeah.
or and they're discharged from ICU, and they're discharged from the hospital, and it's incredibly life changing, isn't it? If
Yeah, it's
that's
huge.
for the person, that you're working with. I had a guy that we just finished a patient last week. He actually was admitted to ICU with pneumonia, and ended up on ECMO, so really, really poorly, and long-term intubation and trachea. Long. He's now decannulated. But the treatment, he was hardcore. He was like, just keep going, whack it up as high as you can. And doing the exercises, I was getting him to practice his motor exercises during the treatment as well, which I presume you guys do that. I asked him, how does it feel? And he said, it's like that. Do you remember space dust? He says, that fizzy popping candy that you put on your tongue. He said, it's like that in my throat. And I just thought that, right, I can really picture that now, how that feels. Yeah, so he's trackies out, he's progressing. It's great how I think the patients get really motivated and compliant and really determined when you're doing the treatment as well. Have you seen that? They
Yeah.
get really brought in, aren't they?
Mm.
Yeah. Has anyone got any final thoughts before we wrap up? I suppose we should wrap up. Anything else you want to add about what you've seen, or the value of it, you think, for you and your service, your team?
Yeah.
Sorry, go on. You go, Rachel.
In terms of like value, in terms of monetary value, I think like obviously the cost of the equipment is absolutely kind of counterbalanced by the treatment outcomes. So the cost of kind of an oropharyngeal dysphagia long term and peg feeding, changing placement. So someone might need to go into long term care. Like the cost of that would be like way more significant than the cost of the treatment. So I've seen it work like so many times, and I couldn't imagine not having it in our toolbox now. I don't think it's the only treatment that we use, but with the right patients, it can be game changing.
Yeah, I completely agree, Rachel. I think, and we've seen as the case I just mentioned, where we've seen significant impact both on resource, so the being able to get somebody out of a hospital, an ITU hospital bed more quickly, getting them decannulated more quickly, but also in terms of the functional outcome for the patient. So being much more less dependent, not having to go to a nursing home, being able to get a peg tube out. So there's all that sort of side of things, and also from a personal satisfaction point of view, I agree, it's not it's not the only tool we have, and it's not going to become the only thing we ever do. But for those patients where before we didn't really have anything except time and hoping things got better, it fills that gap, and it makes something happen quite quickly, and much more quickly than it would have done before.
Yeah, absolutely. I'd echo that as well, that you've got something added to your toolbox that you never had before, which is to treat these sensory patients where you would just be sitting on your hands, really watching, trying your best to do ACV, but sometimes the subglottic port's blocked or they put the wrong tube in. And, so I feel like now we've got something we could use for these patients where we didn't have before. And I think of all the interventions and therapy that we do, which has pretty, very limited evidence. This has got a good level of evidence for it in these certain populations. It's now, recommended by NICE for trachea post-stroke. So it feels like you've got something to use now, where before you were more passive as a therapist, waiting and seeing, really. And I think that is really priceless for those patients, where it can make a huge life-changing difference.
And doctors like it because it's quite medical looking, isn't it?
Well, yeah, so
the profile and the recognition of speech therapy, I think, as we're seen to be really proactive with this treatment, and the dramatic results are not something that just we see. Obviously, the medics see, and I think that speaks volumes for our profile and recognition, and that we don't just sit on our hands, as you said, Ben. So that's a really nice thing to end on. I'd like to just thank you all for your time and for your really, really interesting cases and really valuable insights, and keep up the amazing work that you're doing. And I'd like to thank everyone who's joined us for the webinar, and hope you found it interesting, useful, and as I say, you have our contact details. I'm sure all of us are happy for you to get in touch with us if you have questions or other things that we haven't managed to answer or cover today. So thank you, and enjoy the rest of your day.